Dude, if I'm being totally honest with you, my body was so bad that I had symptoms basically equivalent to chemotherapy.
If you're a manual therapist frustrated with temporary relief where the patients leave feeling better but always come back with the same level of pain, no matter how good your treatments are, you're about to see why. Sal came in December 2023. He had about a year and a half, daily headaches, brain fog, ear pain, jaw pain. Started his TMJ, all 5 fingers were tingling and numb. He just woke up one day and he felt off. So the fact that he's 60% better, this was his 22nd treatment. It's a lot of treatments, but it's a really good sign. And however long it takes to get somebody better is how long it takes. And Sal has other factors with his metabolism and his emotional stress, but this is a really good level of progress for him and he's really happy. He's in longevity now, so he purchased a longevity package. He's also seeing KC for his lower body. So everything is moving in the right direction.
How are you doing since last treatment?
Got a little bit better.
For how long?
It's actually been staying.
Effective treatment should stay. If somebody has relief for 24 to 48 hours, that's not good enough for us. When you see an adhesion provider, you should expect relief to last more than 2 days, typically weeks, typically months, and sometimes you need to snowball enough of getting rid of adhesion so that it lasts enough so that the load being on the body doesn't continue to be high and you have symptoms that come back after 4 days when it's overloaded or 2 weeks when it's overloaded. So the fact that Sal comes in and he says the relief is lasting, that's what should happen when you see an adhesion release methods provider. And this is a standard that we'd also like to see across the board when it comes to any pain doctor or therapist.
Where's the worst spot today, Sal?
I was gonna say probably my neck and head area. Right over here is super tense, and up here as well.
Because Sal has had suboccipital tension and symptoms for a very long time, we spent a lot of time on his greater occipital nerve, his lesser occipital nerve, his suboccipital nerve, his third occipital nerve, and then also the SCM and semispinalis capitis can also refer to the temples where he's having those symptoms. So these are all the tissues on our diagnostic list that we would want to check to make sure that we clear out whatever adhesion is causing those symptoms at his temples. In this visit, you're going to see that we treat the lesser occipital nerves and we give him relief that lasts for his temples.
It actually might be on the sides too, because it feels kind of like it could be like.
Do you feel this right now?
Yeah.
Achy, burning, stabby, throbby, tightness?
I would say more tightness and like more achy.
0 to 10.
Like a 4.
Really good. That's beautiful, actually. What do you feel here?
I felt a little bit of like tension like in here, kind of like I don't know, just like uncomfort.
Pressure or pinching?
Pressure, I guess.
0 to 10.
Like a 3 or 4, kind of like on both sides a little bit back here.
Right here.
Yeah.
0, a pulling, tightness, stretching.
Like a pulling, like 3.
What's really cool about this is that adhesion release methods providers know when somebody has symptoms, let's say it's C7 in the back, which is right where Casey's pointing, they typically will have adhesions on the opposite side because the body works with synergists. There are muscles in the back and there are muscles in the front. They work together to move the head forward or back or just to stabilize the spine. So Sal pointed in the back, but he first pointed in the front. And so we have a double good finding that we need to treat both the front in that area of longus coli or the scalenes down here, and then also the joint capsules, the rotatores, multifidus, erector spinae, spinal accessory nerve in the back side. The same goes for low back symptoms. If somebody has L5 symptoms in the back, we're going to go to the exact L5 area in the front and clear out whatever adhesions are there because we're always looking front to back. Same with knee pain. Someone's got knee pain in the front, we're going to check the tibial nerve, common peroneal nerve, which are branches of the sciatic nerve in the back. This goes throughout the body. So this rule, when somebody has symptoms in the back side, we're going to check for adhesions in the back, but also the front.
Range is at 23 degrees. That's 92% function. CF is at 73 degrees, 121% function. What do you feel here?
I felt pulling kind of in here.
Just the right side?
Mainly the right side. I would say like a 4 there and like a 2 on the left side. And I felt some pulling more so on the left, but on my neck too, on the sides. The left and the right, but like the left was higher, the right was lower.
0 to 10 the pull.
Like a 3, maybe a 4.
On both sides?
I would say 4 on the left, 3 on the right.
Notice how precise Sal is being pointing at his location of symptoms and Casey getting that exact area of where Sal is feeling symptoms. Typically with chiropractors, massage therapists, PTs, there's a lot of shotgunning approaches. If somebody has a symptom in an area, they're going to do an entire neck region or an entire shoulder region. Our theory with adhesion release methods, our working theory, is that there are dime-sized adhesions in those areas that need to be treated, and just those areas, not doing an entire area. It allows us to be more effective. It allows the patient to tolerate more doses of treatment in other areas, and allows us ultimately to get more lasting, more sustained, permanent relief at higher percentages, 50, 75, 100%. If we just spend an hour shotgunning a massage in this area, we're probably going to miss the real area for a 10 to 15 second treatment pass that ultimately removes the symptoms in that spot, so we can move on to the next spot. It's pointing right to the lesser occipital nerve, so I'm hoping that it's stuck. It is. Is that shooting up?
A little bit, yeah. Feels a little bit painful.
Okay. Anytime you push on a spot and it refers to the chief complaint, bingo, you're on the right spot. We will typically ask the patient if we feel like we're on the exact spot that has the adhesion that's causing their symptoms, if it's reproducing their symptoms, and when it does, we know that when we treat that spot in 1 or 2 treatment passes, that spot is going to get significantly better. So the lesser occipital nerve comes out right where my finger is, and then goes up around this way like a horseshoe around his ear, and it's stuck right at the occipital ridge. And the C2 nerve root feels...
Yeah, I feel something there.
The C2 nerve root ultimately becomes the greater occipital nerve and the lesser occipital nerve. So just because the lesser occipital nerve is stuck doesn't mean we can treat the origin or the proximal location of where the lesser occipital nerve is stuck. So the fact that the C2 nerve root is stuck as well is a really good sign that we hit 2 really good spots, and we're going to clear out the symptom for Sal. Moderate. Come on up, check that.
It does feel a little bit better, just overall. I still feel some tension, but it's less.
Percentage less.
Like 20, 25.
So C2 nerve root at anterior middle scalene is bad. Moderate to severe. That's moving better. Notice for the C2 nerve root at anterior middle scalene, 1 treatment pass. This is a constraint that we typically ask our adhesion release methods providers to put on themselves. When there's a bad spot, can you do just 1 treatment pass and make the tissue feel better and softer, that the adhesion's gone, the nerve is now bowing, and you can move on to the next spot. So ideally, I'm doing 3 to 5 treatment passes per visit in order to get people sustainably better. When you're really good at this, you don't need more treatment passes than that. So when you hold yourself to that constraint, it's going to force you to focus on the really bad adhesions as the provider, so that you ultimately get the person better, and then you stand them up and they can say 20% better, 40% better, 60% better. If I'm doing 10 treatment passes or more, not good. It usually means I'm just watering down my treatment and I'm just missing where the really bad adhesions are. Plus our occipital nerve, occipital ridge. I take that back. Moderate to severe, 2 passes. Lesser occipital nerve at temporalis. Right there. It's not wanting to move forward right there. So I'm pushing it. It's not going.
Definitely feel it. I definitely feel a difference, without a doubt. This whole area. Yeah, I would say probably the same as the other side. To me, that's a pretty big improvement.
Nice, Sal. And then we just keep working all the front of the neck stuff so he can hold his head up. C5 nerve root at middle scalene. Yep. Moderate to severe. Two passes case. Also notice I keep telling Casey how many passes I do in each spot. This is to hold myself accountable with that constraint I just told you about, to make sure that I'm being aware of how many passes I'm doing in a spot. 5-10 years ago, when I'm not tracking my passes, maybe I'm doing 20, 30, 40 passes. About that time, my hands were very fatigued and I was thinking of having to quit practice because my hands couldn't keep up with the volume of load. So for the providers, holding ourselves accountable by measuring the number of passes we do in each spot will make sure that we're not overloading our bodies and ultimately getting the patients better results. Two passes case. Three passes. C4 nerve root, middle scalene. Medial supraclavicular nerve at C4.
Dude, if I'm being totally honest with you, my body was so bad that I had symptoms basically equivalent to chemotherapy.
Jesus Christ.
Yeah. I'm just being totally honest with you.
Upper back or like just going down the whole thing?
Upper back, my body couldn't process food properly. Like,
Jeez.
yeah, I mean, dude, if I showed you the notebook, I had to write down all the symptoms I had, and I was going to the Atlas doctor because it was the Atlas bone that I originally had was the issue, and they were like looking at me like, dude, and I'm like, no, bro. I'm like,
Hold. What do you feel here?
I actually felt pulling on the left. That was my right elbow popping.
0 to 10.
Like a 5.
The fact that he still has medial scapular symptoms, I think he's at 4, now it's a 5. It's a little bit worse. So that tells us that that symptom is not a referral coming from a lower cervical disc, usually C6, C7, C7, T1. And so that just means he has local tissue there. So spinal accessory nerve, dorsal scapular nerve, joint capsules, rotatores, multifidus that we would have to clear out in a future visit. All the data always matters, and it just helps us know what we need to work on the next time we see him, so we keep unlayering the adhesions that he has in his body.
More here.
Yeah.
Point at the medial scapula between T4 and T6.
Little pulling in the back of the neck.
0 to 10.
Like a 3 to 4. I would say a 4.
Okay, come on up.
And then there was a little bit on this side that time.
On the right side.
Yeah.
0 to 10 here.
Like a 3.
3 and this is a 2? This was a 4.
4.
If you want to stop chasing symptoms and start offering your patients or clients permanent sustained pain relief, it's time to upgrade your skill set. Adhesion Release Methods is the premier gold standard manual therapy technique to help you find, diagnose, or critically think through and treat those adhesions that's causing chronic pain for people who have seen at least 3 other doctors or therapists without relief. Click below to learn more.